Hemant, start the class.
Yes, sir, sure. Shubh Madhyana, all of you. Myself, Dr. Hemant Pansade, Organizing Secretary for September series. We started this particular webinar series to enhance and update the knowledge of Vikruti Vigyan PG as per time. Today we are having eminent personalities, Dr. Ujjwal Rathod sir as a guest speaker, Dr. Ujjwala Pawar madam as a chairperson, and our RVPGA president, Dr. Subhash Wake sir. Before I start, I would like to invite Dr. Amishiya madam to introduce our organization.
Thank you, sir. Good afternoon and namaskar, respected Professor Subhash Wage sir, Professor Santosh Shavan sir, Naidangi Organizing Committee members, Dr. Hemant Pansade sir, Chairperson, respected guest speaker Dr. Ujjwal Rathod sir, faculty members and beloved students. I am Dr. Anamisha, working as Assistant Professor in the Department of Rogvedan from Parle Institute of Ayurveda. I am here to speak a few words about our organization RVPGA and its significance. But before that, something I have to tell you that in our campus premises, the network is hampered till 2 p.m. So I am doing this through my mobile phone. So if any inconveniences occurred, kindly bear with me. It's highly regretted. About us, our organization RVPGA was formed in the year 2016 under the able and dynamic leadership of. Am I audible? Am I audible, sir?
Yes, madam, you are audible, loud and clear.
Yes,
I
ma'am.
request other
Yes, you are
persons to
audible.
keep their mic mute.
Okay. Yes. Sir, about us, our organization RVPGA was formed in the year 2016 under the able and dynamic leadership of Dr. Subhash Wage sir, with the aim to give the legal status of pathologist and radiologist to the PGs of Rogvedan. Our organization is duly registered under the Societies Act of 1860 at Charity Commission Office, Nagpur. Postgraduate students, teachers of Rogvedan and Vigruti Vigyan can become our member. Ours is the only organization which is fighting for the lawful rights of Rogvedan PGs. Even the NCSM had directed State of Maharashtra to consider RVPG as a stakeholder in the constitutional pathology regulatory body of the state. RVPG is pursuing this matter with the state and central government. Not only this, RVPG is constantly pursuing this implementation of NCSM salary structure in all the private Ayurvedic colleges across the nation. All the communications are uploaded on our website www.rvpga.com. Our activities include regular conduction of online webinars and offline seminars, both on international and national platforms, hands-on training program for PGs at our NABL accredited pathology laboratory, which is a partner NABL laboratory at Mumbai, Nagpur, and Pune. Publication of research papers of Nidan students and faculties in our peer-reviewed journal, International Journal of Diagnostics and Research, IJDR. Interested can visit our journal website, www.ijdrindia.com. Edited book volume series to our international publication RIPI, which is registered in Government of India's ISBN portal. Those who want to contribute book chapter can visit RIPI website www.rvpgaiip.com. We do legal fight for the issues of Rogvedan and Vigruti PGs at appropriate forum. We have our YouTube channel and Facebook page where you can see our educational activities. Thank you so much, sir. Over to you, sir.
Thank you, ma'am, for precisely introduce our organization. Now, I would like to request Dr. Archana Garge, madam, for introducing and welcoming our today's guest speaker.
Thank you, Patsade sir. Hello, good afternoon to all. Myself, Dr. Archana Garge, HOD and Professor Rog Nidan of IMT Ayurvedic Hospital and College and member of RVPGA, welcomes all of you in the today's lecture of Naidaniki Webinar Series 2023. I welcome our today's guest lecturer, Dr. Ujjwal Rathod. I would like to give a brief introduction about him. Dr. Ujjwal Kiran Rathod, he is MBBS and MD in Pathology. He is an associate professor at KEM Hospital and St. GS Medical College, Parel, Mumbai. He is working as a consultant pathologist and he has his expertization in the histopathology and GI pathology. So our today's guest speaker is a renowned pathologist I would like to welcome him. I will also like to welcome Dr. Ujjwala Pawar Madam, who is the chairperson of our today's session. And welcome, Madam. I will welcome Dr. Subhash Waghe also, and I will give him special thanks. He is the president of our RVPGA. He has given me the opportunity to introduce our today's guest speaker in our lecture series. So, without wasting the time, I will request Dr. Ujjwal Rathod to deliver his lecture. Thank you.
Thank you, Madam Archana, Madam, introducing me. And as I start the today's topic, it is microscopic examination of the urine. So, what are the indication for the examination of the urine? So, it is most likely in the suspected cases of the renal disease like pyelonephritis, renal failure, glomerulonephritis, and nephrotic syndrome. Any urinary tract infection like patient having the fever and unknown fever. So, we do the urine examination. And most commonly affected patients are the diabetes mellitus who are prone to the more infection like in UTI. And sometimes we do for the jaundice and blood cell dichresis and during the pregnancy. So these are the physiological, anatomical physiological structure of the both the kidney and the ureter and the bladder, where the just physiology how the urine is formed. Urine is formed by the filtration, reabsorption, secretion, and the excretion, as all of you know. So this is done in the Bowman capsules and the proximal and distal convoluted tubules of the kidney. So while examining the urine, you should collect there are three different, we can collect the different type where you can receive the urine in your lab, like most commonly used is the midstream urine. Then if the patient is in ICU or maybe in the coma, there we can use as a catheterization or maybe the suprapubic aspiration. And 24 hours of urine output specimen need to be collected for the nephrotic syndrome, and like that. So for the after collecting the urine analysis, we do the physical examination, and then the biochemical examination and the microscopical examination. So we go by one. My main topic is microscopical examination, but we briefly go to the other part also. So as of the midstream unit has been you should collect, and I will not go into the details. So these are the sterile urine container most of the lab is used in the most of the lab. And this is a procedure. Just I am going fastly. And these are the urine dipsticks most commonly used in the most of the lab, where you can see there are parameters which are calibrated on the stat strip. And if you dip this into the urine, you will get the color changes. According to that, you have to give the report. This is the easiest way to give the physical examination of the urine, not the microscopic. Microscopically, you need to see under the microscope. So volume of the urine should be normally between the 750 to 200 ml, and it is all depend on the fluid intake, temperature, humidity, exercise, and the fluid excretion of the fluid from respiratory and the intestinal and the skin. So as I already told you, normal is 1.5 to 2 liter for 24 hours. If it is more than 300 ml, 3000 ml, it is called as a polyuria. If it is less than 400 ml, it is called oligouria, and less than 100 is anuria. So most of the commonest causes for the polyuria is diabetes. So most of the patient, if you see the diabetes patient, you see the increasing the volume of the urine more than 3 liter. Then in the chronic renal failure, acute glomerulonephritis or any shock, you see the oliguria or dehydrations. And most of the anuria is the bilateral urinary tract obstruction, or maybe the multiple myeloma, or maybe mercury poisoning. Then there is a specific gravity. Specific gravity is a normal range is a 1 to 0.3 to the 1.030, and it is directly proportionate to the concentration of the solutes and inversely proportionate to the volume of the urine. If it is volume is more, you get the less specific gravity, vice versa. So mostly specific gravity reduced in the diabetes insipidus, certain renal disease, whenever there is excessive fluid intake, diabetes mellitus, dehydration, renal disease. So this is a urinometer which is used to measure the specific gravity of the urine. And it is calibrated at the 15 to 20 degrees centigrade. So I will not go into the deep. So then I will go for the appearance. Appearance of the urine is a clear like a water. Okay, whenever you see the any haziness or any pus in this present in the urine, you see the changes in the urine, like turbidity. So this is the appearance. Then the color. Color is a normal color is a pale yellow, or most of the you can see the yellow and green yellow in the bile, reddish brown in the hemoglobin, like blood in hematuria whenever there is hematuria, and the milky hazy you see in the pus, fat, chyluria, or black currant in the when there is a malin present in the urine, or reddish purple in the porphyrin poison. So just add, this is a repetition of this color. Then the order of the urine is aromatic. Whenever you see the more ammonic, whenever there is a more ammonia, you see the there is a in cases of the black ammonic urine, you see in the whenever there is a increasing the level of the ammonia in the urine, and fruity odor like you seen in the ketoacidosis patient, and musky odor is seen in the phenylketonuria. So normal urine is a pH is acidic. It is mostly 6 to 6.5, and it is tested by the litmus paper. And decreasing the pH we see in the high protein intake, respiratory acidosis, metabolic acidosis, diarrhea, starvation. Like increasing the pH is seen in the those who are eating the high vegetable like citrus fruit, respiratory alkalosis, metabolic alkalosis, like in the vomiting. Then the chemical examination. Chemical examination like glucose and the proteins are most commonest chemical examination we do on the urine. And normally kidney excretes the urine is up to 150 milligram per 24 hours. If it is more than that, it is called as a proteinuria. So how will examine the proteinuria? It is called as a there are 4 methods. One is the heat, commonly used as a heat coagulative test, and the second one is the sulfosalicylic acid test. Third one is Hiller. Fourth one is that is most commonly used in the now all laboratory reagent strip. We put in that and we see the protein is present or not. So for the his coagulative test, you fill up the urine with the 2/3 and add the acetic acid and see the turbidity of the that test tube. And these are the interpretation where pale yellow of the urine, where you won't see the any color changes. Like we go for trace to 1+, 2+, 3+. It is like coagulation. Like we have after heating to the any protein, you get the white color. So it is a interpretation of the heat coagulative test. These are the strip which is used in the most of the labs nowadays. They don't do this heat coagulative test nowadays. So most of the causes for the proteinuria is pre-renal, renal is the most cases of glomerulonephritis, nephrotic syndrome, pyelonephritis. Same thing. And some other albumin is called as a microalbuminuria. This is it excreted 3 to 300 milligram depth per in the urine, and it is a most of the when you see microalbuminuria, it is the earliest sign of the renal damage in the diabetic neuropathy. Then you can there is a Ben Johnson protein where it is seen in the multiple myeloma or maybe the metastatic carcinoma of the bones and amyloidosis. And now every diabetic patients we check the sugar in the urine. So for the to check the sugar in urine, we use the Benedict qualitative test in which we use the 5 ml of Benedict reagent, 2 drop of the urine and boil for 2 minutes, and you see the changes in the urine color. And these are the interpretation where there is a bluish color is negative, and then the 100 milligram 1 plus 2 plus 3 plus, when it is close to yellowish brown, it is a 4 plus. As if all of you know, the increasing the sugar level is always in the diabetes mellitus or some other causes. So I will not go into the details. Then the blood in the urine, most of the it is called as a hematuria, and most commonly it is seen in the urine glomerulonephritis or any tumor infection, pyelonephritis, hydronephrosis, and hematological condition like coagulative disorder, sickle cell disease. And we do chemical test for this is a benzidine test, and it shows the like bluish color on the that tissue. It is a positive for benzidine, that is blood is positive. It is greenish blue color. Then you also check the ketone bodies. Most of the ketone bodies seen in the starvation, severe vomiting, glycogen storage disease. And we use the test is called as a Rothra's test. So this is a interpretation of Rothra's test where you can see the purple ring color in the test tube. So that is a positive for the ketone bodies. Then the bile salt and bile pigment. You do the Hayes sulfur test where in the negative it is doesn't shrink. In the positive test, so its sulfur powder goes downward to the bottom of the test tube of the urine. So it is a positive for bile salt. And for the bile pigment, you do the Gemelin nitric acid test where you can see the green color on the fountain reagents. So this is a positive for the bile pigment. Then we go for the microscopic examination of the urine. Okay. To go the microscopic examination of the urine, most of the time you can see the squamous cells. Sometimes you see the WBC, and if they are more than 5 to 10 WBC per high power field, it is a significance and it is abnormal. And whenever you see the RBC is more than 5 per high power fields or any cast, it is all the abnormals. So you see the Highland cast, Waxy cast. You can sometimes see the mucus thread or granular cast, sometimes yeast, and you see also crystals. Crystals are more important where you can see the acidic urine. Most commonly you see the calcium oxalate crystals, followed by the uric acids and the cysteine and sodium urate crystals. And in the alkaline urine, you see the most of the commonly the triple phosphate, then the calcium phosphate, calcium carbonate, and the amorphous phosphate material. So already told you the normal level of the WBC is 4 to 5 per hour will be, and whenever it is a more than 4 to 5, we suspect the infections. The most common is cause of the increasing the pus cells in the urines are the pyelonephritis, any infection to the renal parenchyma, glomerulonephritis, like urinary bladder infection like cystitis, or maybe urethral infection, urethritis, chronic pyelonephritis, prostatitis, pyogenic infection, acute appendicitis, pancreatitis, or maybe in the tuberculosis or urinary bladder rare condition, that urinary bladder tumor. And non-bacterial causes is like SLEs, interstitial nephritis, glomerular nephritis, or tumors. So these are the microscopic features where this is a high power field like 40x, where you can see the more than almost 25 to 30 pus cells. And in this right side, you can see the more than 60 to 80% cell count of the that pus cell. So these are all the pus cells which are seen in the microscopically. So this is slightly higher power where you can arrow part is showing the pus cells. So how to differentiate between the pus cells and the red blood cells and the epithelial cells? The epithelial cells are the like squamous cells, and the pus cells are slightly bigger than the RBCs, and RBCs are the refractile. You can see here these RBCs are the refractiles, but they are more in number. Like these are the pus cells. We call it as the WBC pus cells. Sometimes you see the pus cell cast. Whenever there is a pus cell cast is highly indicative of the infections. And sometimes you see these are the candidal hyphae, pseudo hyphae, where you can see these are the candida, and these are the broad pseudo hyphae and candidal buddings. So this is a infection of the candidiasis in the urine. And these are the mucus or fungal elements. Normally, sometimes you see in the urine, but they are not significant. Like they doesn't cause any harmful, but the candidiasis can lead to the candidiasis infection to the candidiasis urethritis, or maybe the infection to the patient. Then another things are seen in the microscopic examination is a squamous cells. These are the mature squamous cells where you can see the polygonal shapes or hexagonal shape of this squamous cells in the central small micronuclei. So these are the stratified squamous cells. These are the lining of maybe the urethra or maybe the epithelial lining, which are just get while during the urination you see this increasing that epithelial cells. We call as this is the epithelial cells. Then there are these are the RBCs. I already told you RBCs are the refractile. They are smaller than the pus cells, and mostly these are seen in the like most commonest causes of trauma, acute infection, inflammations, and cognitive disorders. And this microscopic hematuria is seen in the glomerular disease, malignancy, and maybe renal calculi. These are the microscopic examination where you can see the more than 80 to 90 RBCs on the left side, and the left side there are few, and you can also see these are the pus cells. But whichever the refractile are there, they are the RBCs. Same picture showing RBCs which are all refractile. And whenever there is you see the clumping of these RBCs is called as a red cell cast. Okay. So there are the other casts also we can see in the urine. There are like in the hyaline cast, granular cast. Granular cast is more significant in the tubulointerstitial disease of the kidney. And already I had told you like a WBC cast and the RBC cast. Sometimes you see the waxy cast in the chronic renal disease, and fatty cast in diabetic neuropathy. So we go one by one how they look like. So these are the different type of the cast, where you can see the highline cast. It is a translucent homogeneous, where you see the granular cast are more granular. You can see there is increase the granularity, like in the coarse granules, like fine granules, or with the waxy. These are all the type of the cast. And in the highline cast, there is a mix up of the fat also. These are the fat which are the refractile. So this is a diagrammatic pictures where you can see the highline cast, fine granular cast, WBC like pus cell cast, RBC cast, then fatty cast, waxy cast, or mucus thread. So most of the granular cast, it is a, I already mentioned, it is a seen in the tubulointestinal disease. This is the actual microscopic pictures, and the purple arrow which is showing the granular cast, and it is mostly seen in the acute tubular necrosis, pyelonephritis, glomerulonephritis, or maybe rarely conditioned nephrosclerosis. And which are these granular cast may be accompanied with the red cell cast, epithelial cast, or WBC cast. Whenever it is accumulated with the red cell, there is always diagnosis towards the glomerular injury, or whenever it is seen with the epithelial cell, it is a renal tubular injury, or it with WBC indicate the infection, any pyelonephritis or interstitial injury. Then the highline cast, already told you, this is a transparent homogeneous actual highline cast, which is also seen in the glomerulonephritis, renal disease, pyelonephritis, or congestive heart failure, or any renal failure. Already told you epithelial cast. These are the all squamous epithelial cell which are clumped together and forming the cast. These are the waxy cast. It is mostly seen due to the degeneration of the granular cast, and they are like slightly homogeneous, colorless, but not that much of the waxy highline cast. Then the fatty cast. Fatty cast are there. They are the like fat globules which are the refractile, not as RBC, but they are irregular shape, and they are aggregated. So that's why it is called as a cast. And mostly it is seen in the nephrotic syndrome and the toxic renal poisoning. Then there are the crystals, like most of the crystals like seen in the alkaline urine, like calcium oxalate is mostly seen in the alkaline urine, like calcium phosphate and cholesterol, and these all phosphates are seen in the alkaline urine. So this is a diagrammatic picture where you can see the calcium oxalate, which is a like rectangle and like oval and dumbbell shape, and this is a square, and triple phosphate is a rectangular, and where you can see the hexagonal rectangular shape, and the calcium phosphate where you can see there are the spike like deposit crystals seen in the urine, and there is a square which is uric acid crystal, irregular shapes, but one end is a slightly thickened here to differentiate between the calcium oxalate and the uric acid. One end you always see some thickened area, and then the cystine. Same thing, repetition of that crystals. So already told you these calcium oxalate crystals, they are refractiles and rectangular, and which spherical to biconcave from the one side, and mostly seen in the acidic urine. Then these are the uric acid crystals. These are the uric acid crystals. We can see as a diamond shape or maybe square shape. With the one end is a thickened. I told you it is one end out of 4, One end is always thickened. So this is a uric acid crystals. And mostly seen in the, as you know, the uric acid are increased in the gut, chronic nephritis. Then the amorphous urate crystals. Amorphous urate crystals is a sodium phosphate magnesium calcium crystals. These are the salts where you can see the yellowish red granules appearance, reddish grain in the urine. This is not significant. There is clinically is not significant, but sometimes you see. Then the sodium urate. They are the like colorless yellowish needle-like structures, so, like spike, like wheel spike. Okay. This is also doesn't have any significant in the urine, but we found in the those patient having the stones and all that. Then calcium sulfate crystals. They are the. It is also like prism. They are long, colorless, needle-like, and prism, but they are not coming like a spoke. Okay, they are only 1 to 3 branch like needle prism. And the hypuric acid crystals, which is also colorless, and they are like a flat plate-like structure or prism, elongated prism. And the cystine crystals. Cystine crystals are they are occur in the mostly congenital cysturia, and they are the mostly hexagonal in shape and homogeneous plate-like structure, colorless. And the tyrosine. Tyrosine is like a refractile fine needle. It is like in the phosphate crystal, you don't see that much fine. Here you can see there are the fine like spoke, and there are multiples, and soluble in the ammonium oxalate, and it is a most of the seen in the severe liver disease and the tyrosinosis deficiency. Then the leucine crystals. If you see, these are there is a leucine crystals. In between, these are the pus cells, and whatever the yellowish refractile you see, this yellowish brown color, these are the leucine crystals. They are refractile, oval, round, refractile, spheroid color leucine crystals. Then the sulfur crystals. Sulfur crystals are mostly those patients who are taking the sulfur drugs. You see this type of the like dumbbell shaped needle like a brown, red to brown color is eccentric binding. This is the sulfur crystals. And the most commonest crystal seen in the alkaline urine is a triple phosphate, where you can see the prism with the 6 side. Okay, and these are the rectangle, not the square one. Like square one are the calcium phosphate, calcium carbonate, not the triple phosphate. Then the like amorphous material already told you, they are present like amorphous granular cast, not significant. Then the calcium carbonate, they are a small spherical dumbbell shaped granular cast. Then the calcium phosphate, these are the colorless prism, and one side is pointed, other side is a like rosetting appearance. Then the ammonium biurate crystals, which are spherical, irregular shape. They look like spicules, like calcified body-like structures. So these are we are finished with the crystals, and sometimes we see the artifact in the urine, like hair, air bubbles, oil bubbles, or maybe there's some starch crystals. So you have to avoid this, and if they are significantly seen, we have to do the make the other slide and see it under the microscope. Thank you very much. And any question or any doubt? Hello.
Hello, sir.
Yes, yes.
Please ask question. Anyone?
Any question?
I think sir has nicely covered the all topic, all relevant portion related to the urine microscopy, and this is more than sufficient. And particularly at a time when our regular speaker had conveyed her inability to deliver as she is suffering from the dengue, and we had asked the sir at the 11th hour yesterday only, and yesterday only the sir had prepared all the slides and came for our rescue. And despite at a very short notice, he had spared time with us. I think almost all the points are covered. Even then, if somebody has any question, they can raise.
Okay. I think I had covered most of the urine microscopic structures.
Yes, sir.
And little bit
Yes,
other
yes,
structure. Yes, yes, madam. Any question?
So next, switch on to the vote of thanks. I think it's time.
Okay, no problem.
Okay. Sir.
Hello.
Thank you very much, sir. For
Yeah,
very
yeah.
yes,
Thank
yes,
you for
yes, ma'am.
inviting
Please.
me for the this lecture-based lecture. And thank you
Someone
for the Santosh.
someone
Thank you
raised
for
hand.
the Saurabh and all the dignitaries who are listening to me.
Sir, someone raised hand.
Okay. So
Yes,
what is the question?
Dr. Wad, please ask.
Sir, good afternoon.
Sir, good afternoon. Good afternoon.
Sir, some patients having glucosuria, but glucose BSL random fasting PP are normal. Clinically patient stable.
Okay.
Then what we do?
Okay. Fasting and which one is normal?
Sugar levels are normal.
Okay.
When we do fasting, postprandial, random,
Okay.
but urine sugar is present.
Okay, okay. This is a residual urine.
Clinically,
Yeah. This is a residual urine because what happened? Her bladder sometimes doesn't throw all the urine. Some urine is remain in our bladder, so it is called as a residual urine. So whenever the patient is take on the diabetes or maybe they take the anti-diabetic drugs and sometimes the residual urine is remain in the bladder, so that may show the urine sugar positive.
but patient is non-diabetic.
Non-diabetic also is
In non-diabetic.
non-diabetic.
And repeated urine sugar is
Then it is
urine sugar is positive.
No. You don't see the urine sugar in positive such a cases. So how many cases you have seen this happening?
I think 2-3 cases I have seen. Glucosuria,
cases.
non-diabetic patient. In non-diabetic patient.
Non-diabetic patient. Might be you are doing on the strip or which method you are doing?
Strip.
So you go with that chemical examination and like that benzene test and all that. So that will be helpful if you are finding the.
Okay.
Yeah.
They may be pre-diabetic patients, may not be actual diabetic, but maybe pre-diabetic.
Yeah.
Okay.
Then you do the HbA1c and you look for what is the status.
Okay. Thank you.
Yeah.
There is a question in a chat box, sir.
Sorry.
HbA1c value can be referred.
Yeah, chat box, there are some. Can be refer. Hello.
Yes, sir.
So, someone has suggested, it is not a question. Actually, he has suggested to the other person who was asking the question.
Okay. No problem. Sir.
This is not
You
a
can
question.
HbA1c value always you can confirm with the HbA1c.
I think we should sum up.
Okay.
Yes. Thank you, sir.
Yeah.
Giving us a very informative and knowledgeable lecture. Now, I would like to request Dr. Ujjwala Pawar, madam, for chairperson remark. Dr. Pawar, madam. I think there is some.
I think she has left.
Yes, Hemant sir. Ujjwala Pawar ma'am is here, no?
Yes, Hemant. Yes, Hemant.
Yes, she is there.
Audible? May I audible, sir?
Yeah, ma'am, you are audible.
Yes, you are audible, ma'am.
Yes. Okay. Thank you so much, Hemant. Yes. Good afternoon to all of you. Here I am Dr. Ujjwala Pawar, Professor and Head of the Department in Government Ayurved College, Nanded. I am delighted to be here to chair this wonderful and knowledgeable session on the topic of urine microscopy presented by Dr. Rathod sir, MD pathologist in SET, GSMC and KM Hospital. So first of all, thank you so much, Dr. Waghe sir and the entire team of RVPGA for inviting me to chair this session. Actually, Dr. Rathod sir already touched each and every point, like the indication of urine examination, physical examination of urine, chemical examination of urine, and in briefly, but microscopic examination in detail. He already explained with beautiful pictures, and I would like to tell you all there is some one question that's it's shows Dr. Rathod sir explained very well. So they already told us, explain us regarding RBCs, WBCs, types of cast crystals, and all the significance of these cells. So I will like to add some words in this topic regarding Ayurveda. Because all PG students understood that how important diagnostic tool is urine microscopic in the diagnosis of disease. So I would like just 2 or 3 points. Acharya Yogaratnakar already mentioned the examination of urine, and in ancient era, urine test is considered as one of the 8-fold test for the examination of the patient. That is, we know Ashtavida Pariksha, Nadi Mala Mutra Shabda Sparsha Dukakruti. So the Mutra Pariksha is very important diagnostic tool in that ancient era also and in this modern era also. Acharya Sushruta also said about Samata, Samata of Mutra, Sama Mutra Pariksha. What is Samata? When Mutra associated with arm, it gets contaminated, and so urine gets dense and toxic. And it changing is and urine change in color and odor. So we can see this type of many type of urine in types of prameha. So explain it is explained by, and Yogaratnakara also explained the major and main topic, that is Taila Bindu Mutra Pariksha. So this pariksha is also important in that era. For Mutra Taila Bindu Parikshan for ascertaining diagnosis and prognosis of disease, what is Taila Bindu Parikshan? So this is the test by dropping oil in urine it is mainly based on the direction of oil spreading in the sample of urine. Just one drop of oil is dipping in urine and urine sample and examine the action during sunlight. So Taila Bindu Pariksha indicates the involvement of doshas and its prognosis and whether the disease is curable or not. That is the incurability of disease. And already we say about that Arishtam. So these three main points I want to add. I would like to add this. So thank you so much again. And actually, I congratulate Dr. Rathod sir because of in short period and in short in way he accept this invitation. So thank you so much, Dr. Rathod sir, and thank you so much the entire team of RVPGA. Thank you so much.
Thank you very much, madam, for adding the like Ayurveda.
Yes, sir. Ayurveda. Yes, sir. In Ayurveda, it is very important diagnostic tool also in that area. So I just want to add this.
Thank you.
Thank you.
Thank you so much, ma'am.
Yes.
Now I would like to invite Dr. Rasika Taide, madam, for vote of thanks.
Hello, thank you, sir. Good afternoon, everyone. Myself, Dr. Rasika Taide, pathology practitioner at Amravati, Maharashtra, and RVPGA life member. Today, I feel very pleasure and thank you to Dr. Waghe sir and Panchade sir to give me an opportunity to propose the vote of thanks on the behalf of RVPGA Nidanic webinar series. Today's webinar's guest speaker and renowned pathologist, Dr. Ujjwal Rathod sir, has given a very knowledgeable, informative lecture on the topic of microscopic examination of urine. And also thank you, sir, for sharing your valuable practical knowledge in such a short duration to our practitioners, PG callers, and participants. Thank you, today's webinar chairperson, respected Dr. Ujjwala ma'am, for their valuable Ayurvedic interpretation of urine. Thank you so much, ma'am. Thank you, Dr. Ashwini ma'am, for welcome speech. Also, thank you to Dr. Ambatiya ma'am for introduction of our association. Thank you to MCIM Mumbai for giving approval of Nidanic series. Thank you so much, sir. With permission of my organizing secretary, Dr. Hemant Panchade sir, I declare that today's session is over. Thank you. Thank you so much.
Thank you very much. Thank you.
Thank you.
Thank you, ma'am. Thank you.
Thank you everyone for joining this wonderful webinar series that lasted for
Thank you.
almost
Have a
2
good day
months.
to all of you.
And
Yes, thank you.
we can end the meeting now.
Yes, thank you, sir.
Thank you, sir.
Thank you, sir.
Yeah. Ujjwal sir, thank you. Thank you. Thank you so much. Yeah, you can leave the session, sir.